Clinical vignette, heart failure. A 72-year-old man with a history of hypertension, coronary artery disease, and type 2 diabetes mellitus presents to the emergency department with progressive shortness of breath and swelling in his legs over the past 2 weeks. He reports orthopnea and paroxysmal nocturnal dyspnea. He denies chest pain or palpitations. On physical examination, his blood pressure is 104 to 85 millimeter Hg ground, heart rate 92 BPM, respiratory rate 22 min, and oxygen saturation 92% on room air. He has jugular venous distension, bilateral crackles in the lungs, an S3 heart sound, and 2+ pitting edema in both legs. Laboratory results: BNP 1,200 pg/ml, normal 100 pg/ml. Serum creatinine 1.5 mg/L. Echocardiogram, left ventricular ejection fraction equals 35 cent, global hypokinesis. Question: which of the following is the most likely diagnosis? Heart failure with preserved ejection fraction, HFpF. B, heart failure with reduced ejection fraction, EF. C, acute pericarditis. D, chronic obstructive pulmonary disease, COPD exacerbation. Correct answer B, heart failure with reduced ejection fraction, 8F. Explanation: this patient presents with classic signs and symptoms of heart failure, including dyspnea, orthopnea, pulmonary congestion, JVD, pitting edema, and an S3 heart sound. His echocardiogram shows an LVEF of 35%, confirming heart failure with reduced ejection fraction EF 40%. Why not the other options? A, HFpEF, heart failure with preserved EF, usually occurs in elderly, hypertensive, or obese patients with diastolic dysfunction and normal EF, 50%. This patient has a reduced EF, ruling out HFpEF. C, acute pericarditis, presents with pleuritic chest pain relieved by sitting up, pericardial friction rub, and diffuse ST elevations on ECG. Not consistent with this case. D, COPD exacerbation, would present with wheezing, hyperinflated lungs, and respiratory distress, not pulmonary congestion and an S3 gallop. Key features of heart failure types: feature HFrEF, systolic AF, systolic HF, diastolic S3 gallop. Ejection frac 40%, reduced tension 50%. Primary problem: impaired contractility, impaired relaxation. Common causes: ischemic heart disease, dilated cardiomyopathy, hypertension, obesity, aging, heart sound, S3 gallop, volume overload, S4 gallop, stiff ventricle. Treatment focus: reduce afterload, improve contractility, control BP, reduce congestion. Management of HFpEF. First-line medications: ACE inhibitors, ARBs, reduce afterload and mortality. Beta blockers, carvedilol, metoprolol, bisoprolol, reduce mortality. Diuretics, furosemide, spironolactone, symptomatic relief. SGLT2 inhibitors, dapagliflozin, empagliflozin, reduce hospitalizations. Would you